So as we move ourselves around, we finally get to zone 0, which is the ascending aorta. And there are a number of problems with the ascending aorta that need to be addressed. First of all, it's the largest portion of the aorta, which means if we're going to be deploying grafts here, the grafts are going to be larger, the devices are going to be larger, the equipment to introduce up a vascular tree is going to be larger, which may pose access issues and may create the possibility of more access complications if patients aren't properly selected for this procedure. The ascending aorta is a viscoelastic structure, a lot more so than anywhere else in the aorta, and it has a catch and throw function. So if you look at what happens in systole, the heart beats, the ascending aorta expands, and then it contracts down and actually assists with the flow of blood down the remainder of the aorta, assuming competence of the aortic valve. And there's some evidence, in fact, that suggests that this is an active process mediated through some of the smooth muscle cells within the wall of the aorta. If you stent graft this area, you're going to take away all of that particular physiologic function, and we don't know what the consequences of that are. The proximal and distal landing zones are potentially problematic. Embryologically speaking, the ascending aorta develops from a different cell type to about the level of the left common carotid than the remainder of the aorta. Ascending aorta and the proximal arch develops from neural crest cells as opposed to the remainder of the aorta, which develops from mesenchymal and mesodermal cells. And this raises the issue of so-called regional heterogeneity of the cellular and biochemical functions within the aorta. And I say this because ascending aneurysms in general don't stop at the innominate. They go up and they involve the proximal arch. The vast majority of them do. So don't assume that you're going to be able to deploy a stent graft within the ascending aorta with good landing zones proximally and distally. You're going to have to deal with the innominate artery. You need technology to deal with that. Proximally, the problem is that you have the sinotubular junction, and then after that, you've got the aortic valve. Both very difficult places to land a stent graft. A significant number of ascending aneurysms occur in young people that have connective tissue disorders. Marfan syndrome, Ehlers-Danlos syndrome, bicuspid aortic valve disease, Turner syndrome. These are the patients that we treat. These are the patients that we perform open ascending aneurysm replacements on. These are young patients. They're in their 30s to 50s. They want a durable result. Most thoracic stent grafts are designed with the 10-year plan in mind. And we need more than that for these patients. Here's an example, again, that was alluded to earlier of use of an open debranching procedure to get to zone 0, where a branch graft is placed to the great vessels, which then allows, and then anastomose to the proximal ascending aorta, which then allows a graft to go all the way around. And this is performed generally by median sternotomy, and I would make the argument to you that the exposure and the technical difficulty of this is not much different than just replacing the arch open, but perhaps this is something we could talk about in the discussion. Here's a complex debranching procedure to access the ascending aorta. I'm not going to go through it with you in a lot of detail other than to say that there's some very imaginative approaches available to use debranching, et cetera, to get to the ascending aorta. Here's a patient with a ruptured penetrating ulcer of the ascending aorta. Pretty rare condition, but here's an unusual situation where there's actually a proximal and distal landing zone in the upper left-hand corner there, right here. So it's actually possible to deploy a regular endovascular stent graft and cover this area, but as I was talking to Dr. Lee a little bit earlier, there's probably less than 10 cases published in the literature on stent grafting of the ascending aorta. It's pretty unusual at this point. And I put this slide up to illustrate the fact that not all zone zeros are the same. On the left-hand side, you've got a pretty bulbous ascending aortic aneurysm, but this isn't the only thing we see in the first part of the aorta. On the left-hand side is a patient with Marfan syndrome who suffers from annuloaortic ectasia with a large aortic aneurysm, a large aortic annulus and aortic root aneurysm. These two are very different anatomies and would pose very different issues with regards to stent grafting. They're not all created the same. And this is where I propose a new classification where I think that we need to have an extra zone in the aorta, and that zone should be zone 00 or zone X, or maybe you want to put a skull and crossbones there. But that particular zone should be in the area of the aortic root from the sinotubular junction to the aortic valve, because it poses a completely different set of issues that are going to have to be addressed if we are going to be successful in stent grafting that area. So, features of the ideal zone 0-0 stent graft. Well, it's going to have fixation most likely at the aortic annulus, and the problem with that is that you must have secure fixation with no paravalvular leak into the left ventricle, because you don't want these patients to get aortic insufficiency afterwards. It has to have side grafts which are going to go into the coronary arteries and probably up into the innominate, so that's pretty complex. It's probably going to need to have a tapered design to allow for discordant proximal and distal sizes. And I envision a situation where these sorts of grafts may be custom synthesized using a 3D imaging platform and then transfigured into some sort of manufacturing platform, something that we clearly don't have yet, but I think that we probably would need to get accurate, properly designed grafts. Now, some of this is already in place, and I think you may have seen a little bit of this earlier, but one of the things that we have in place is that we can now deploy an aortic valve percutaneously with success. And this is the Edwards Sapien valve, which is a pericardial valve that's mounted on stainless steel. And this can be deployed through a transfemoral, but also a transapical route across the left ventricular apex through a small left thoracotomy. And I have here, oopsie. Just give me a sec here.
With the mouse, please, on the video, with the trackpad.
I think you did it. Thank you very much. So here's a cartoon, again, shared with me by the Edwards people. Two issues. First of all, you have to have a pacing wire placed up via the inferior vena cava into the right ventricle for rapid pacing. Then a guide wire is placed across the aortic valve into the ventricle. This is with a patient with aortic stenosis, so the first thing that has to happen is that the aortic valve is dilated under the conditions of rapid cardiac pacing to prevent migration of the balloon. Sinus rhythm is restored, the balloon is retracted, and a percutaneous aortic valve. It comes in two sizes right now, I believe a 23 and a 26, pre-crimped onto an introducer, goes up the descending thoracic aorta around the arch across the valve. Again, rapid cardiac pacing so that the device doesn't migrate. Deploy across the aortic valve, remove the angioplasty balloon, and there you have it. Remove the guide wires, and the operation is completed, and you have a transcatheter aortic valve replacement that can also be done through an introducer placed through the left ventricular apex. This whole procedure in experienced hands takes about 30 minutes to do. Here is an example of a clinically deployed one. As you can see, they do things in Vancouver besides host the Olympics. Here's the deployment of the valve. The transesophageal echocardiographic probe there, as you can see. And then a completion angiogram, which shows excellent placement of the graft, non-obstruction of the coronary arteries, and no paravalvular leak. As I mentioned before, incorporation of devices such as these are going to be critical in being able to access the coronary arteries and the innominate artery. So to conclude, I think that we have continued technical and device advancements which have allowed more of the aorta to be accessed through endovascular stent grafting. I think it's a very exciting time, and I look forward to further developments. And I think the final challenge, or the final frontier, if you will, proximal ascending aortic and root stent grafting will require continued development and integration of new percutaneous aortic valve and stent graft construction technology. Thank you very much.